So now we move into part 2 of the female reproductive anatomy, looking at the vagina. The vagina is the birth canal. It's about 8 to 10 centimeters of distensible muscular tube. It allows for discharge of menstrual fluid, the receipt of penis and semen, and the birth of a baby. The vaginal walls consist of an outer adventitia, a middle muscularis, and an inner mucosal layer. It's tilted posteriorly here between the bladder and the rectum. The vagina itself has no glands. However, it's lubricated by the process of transduction, which is where serous fluid literally sweats through its walls, and there's a little mucus from the cervical gland above it. The tip of the uterus at the cervix dips down into the roof of the vagina and creates these fornices, which are blind end spaces on either side of the cervix. There are transverse ridges at the lower end of the vagina called vaginal rugae. They add extra stimulation. And mucosal folds form the hymen across the vaginal opening, which is often actually destroyed prior to the first sexual intercourse by insertion of tampons or medical examinations. The vaginal epithelium has a big transformation at puberty. In childhood, it's simple cuboidal. But the presence of estrogens are going to transform it into stratified squamous epithelium. This is an example of metaplasia, where we see the transformation of one tissue type into another. We'll also see a good culture of bacteria in the vagina, and they ferment glycogen, which is converted into lactic acid, and that's what accounts for the lower pH or greater acidity in the vaginal environment that protects it from invaders. Also, we'll see that there are antigen-presenting dendritic cells. These are actually the route by which HIV from infected semen could invade the female body. So the external genitalia are collectively called the vulva or the pudendum. They consist of the mons pubis, the labia majora, and the labia minora, and the clitoris. The mons pubis is a mound of fat that covers the pubic symphysis, and it bears most of the pubic hair. The labia majora are a pair of thick folds of skin and adipose tissue that are inferior to the mons. They form the pudendal cleft, which is the slit between the labia majora. Inside the labia majora, we'll find labia minora, which are hairless folds, much thinner, and they're medial to the labia majora. The space between the folds forms the vestibule, which contains urethral and vaginal openings. The anterior margins of the labia majora join to form a hood-like prepuce over the clitoris. The clitoris is composed of erectile and sensory tissue. It doesn't have any urinary role. It's the primary center of erotic stimulation. It has a glans, or head, a body which extends internally, inferior to the pubic symphysis. It also has corpora cavernosa, as the penis did. That's the erectile tissue. And it diverges at its internal end as a pair of crura, just like those that we see at the male penis. There are vestibular bulbs, which is erectile tissue that's deep in the labia majora. This causes the vagina to tighten around the penis externally and enhance the sexual stimulation. There are also a series of glands that are analogous to the glands that have secretions into the seminal fluid. In the female, we have the greater and lesser vestibular glands and the paraurethral glands, and they open into the vestibule of the vagina and create the lubrication that we see during sexual arousal. Different than the vaginal sweating we saw for just the regular everyday vaginal lubrication. So finally we come to the breasts. The breasts are a mound of tissue that lays over the pectoralis major muscle. They enlarge at puberty in the female and remain at that size in general for life. Most of the time they contain very little mammary gland. Mammary glands actually develop within the breast during pregnancy and remain active throughout lactation, and it atrophies when a woman ceases to nurse. There are two principal regions of the breast. There's the body and the axillary tail. So the body is this conical and pendulous region of the breast with the nipple at its apex. And the axillary tail is the extension of the breast that moves up towards the armpit. There are lymphatics in the axillary tail, and they have a big role in metastasis in breast cancer. So they're often removed during a mastectomy. The nipple is surrounded by a circular, slightly pigmented zone called the areola. It's got a higher density of capillaries and nerves that are closer to the skin surface, which makes it very sensitive. This extra sensitivity of nerve fibers in the areola is what triggers the milk ejection reflex as an infant nurses. There are areolar glands, which are intermediate between sweat glands and mammary glands. They produce secretions that protect the nipple from chapping and cracking during nursing. There are smooth muscle fibers in the dermis of the areola that contract in response to cold, touch, and sexual arousal. This causes wrinkling of the skin and erecting of the nipple within the areola. In the non-lactating breast, we see mostly adipose tissue. This is an image of a lactating breast, where we can see full development of the mammary tissues. Breast size is determined simply by the amount of adipose tissue, of course, unless there's an augmentation with a bag of saline. The suspensory ligaments attach the breast to the dermis of the overlaying skin, as well as to the fascia of the pectoralis major. There's a system of ducts through the fibrous stroma that converge in the nipple. The mammary gland again develops during pregnancy. There'll be about 15 to 20 lobes like these pink ones here around the nipple. They have lactiferous ducts that drain each lobe, and then they dilate to form the lactiferous sinus, which opens into the nipple, and that produces milk. Here we can see a dissection of breast. You'll notice that it's predominantly adipose tissue. We can see a few of the suspensory ligaments, but other than that, in a non-lactating breast, predominantly adipose tissue. Now, breast cancer occurs in about 1 out of 8 American women, so it's got a very high incidence. Usually the tumors begin within the cells of the mammary ducts, and they can metastasize to the rest of the body by mammillary and axillary lymphatics. So lymphatics in the axillary portion of the breast, as well as other lymphatics in the armpit region. Signs are palpable lump, which could be the tumor itself. We might see skin puckering in that area or changes in the skin texture. And drainage from the nipple is a strong indication. Most breast cancer is actually non-hereditary. In the 90s, we found a couple of different genes, BRCA1 and BRCA2, and many women who have breast cancer or may think they're at risk of hereditary breast cancer will have a genetic test to see if BRCA1 or BRCA2 is there. However, these are not the only hereditary forms of breast cancer. These are just markers that we've found. I'd imagine that there are thousands of other possibilities of mutations that could lead to breast cancer. These are just 2 that we know about. So breast cancer seems to be much more common among women who begin menstruating early in life and who reach menopause relatively late. That is really women who have had a long period of fertility and exposure to estrogen. Estrogen is one of the primary risk factors. Other factors include aging, exposure to ionizing radiation, carcinogenic chemicals, excessive alcohol intake, and excessive fat intake, as well as smoking. 70% of cases seem to lack any sort of identifiable risk. Most tumors are found during breast self-examination. This is the best way to find a tumor. Mammograms are breast x-rays, and we'll start in the late 30s with a baseline mammogram, usually. And between 40 and 50 years, we should have a mammogram every 2 years, and above 50, we should have a mammogram every year. But most important is the monthly self-examination. A woman can get used to the texture of her breast, and any lumps that show up will be relatively obvious if we're familiar with the process. There are several different possibilities for the treatment of breast cancer. Now, something I want to bring into our minds is the fact that the breast cancer industry is indeed a business. Personally, my mother has been through breast cancer, and my advice is that anybody should have an advocate with them in order to try and make these decisions. There are choices of lumpectomies, simple mastectomies, radical mastectomies. Lumpectomy is simply removal of the tumor, and you still have a breast. A simple mastectomy is removal of all the breast tissue and some of the axillary lymph nodes. Radical mastectomy involves removal of the breast, underlying muscle and fascia, and lymph nodes. So the choice that's made here, a lot of people will choose just a lumpectomy because they want to maintain their own breasts. However, this is going to require radiation or chemotherapy as well, and radiation treatments and chemotherapy treatments are very expensive. And so what do you think the doctors would prefer? There's a lot of ethics to be considered in the field of breast cancer. Now, a full mastectomy is a very radical procedure, but breasts can be reconstructed from your own skin, fat, and muscles from other parts of the body. And these days, they can actually do a very good job of reconstructing the areola and the nipple, and make very realistic looking reconstructed breasts. So this concludes our section on female reproductive anatomy. Next, we'll move on to puberty and menopause. See you soon.